Hi, I'm Naomi Murphy, and this is the Locked Up Living podcast, where we talk with a wide range of people about harsh aspects of institutional life.
We also explore some of the ways to overcome them and to grow and develop. I'm David Jones. So join us every Wednesday morning, 6 o'clock UK time, for a fresh podcast.
So our guest today is Elanor Webb, who's a research associate and lecturer working in the Centre for Developmental and Complex Trauma at St Andrews Healthcare. Her work focuses on improving outcomes for people exposed to psychological trauma, with a particular focus on forensic populations. Elanor recently completed a PhD at the University of Central Lancashire, exploring moral injury in secure mental health care staff. Really glad to have you along to discuss this topic with us today. Welcome.
Thank you. Thank you for having me.
Hi Eleanor, great to meet you. Thanks very much for coming along. So, what is moral injury and what are the signs of it? Let's get straight into it.
Good question. So we kind of have, I suppose, two sort of main definitions for moral injury. So the first was one that was developed by someone called Jonathan Shea, and then we have a more recent one by someone called Brett Litz. So I suppose, to put it kind of as simply as possible, it's essentially a kind of form of distress that we see that can arise when someone experiences an act or a kind of an event that goes against their moral values. So the kind of original definition from Jonathan Shea was very much focused on kind of externally driven causes. So experiences where someone has felt that they've been betrayed by someone else, specifically someone in an authority position. And then we had a much more recent definition, which came from Brett Litz, which really expanded that definition to consider kind of self-transgressions, so distress that might arise when we ourselves do something that goes against our own kind of moral values. And so I suppose it really kind of removed the focus on like an authority figure as being kind of the sole sort of catalyst for this kind of distress, recognising that actually we might also act in ways that goes against our own moral values as well. In terms of kind of what moral injury looks like, it's a tricky one because it's not a diagnostic construct. So it's not like PTSD where, it exists in kind of diagnostic systems, and it has a very kind of clear sort of set of symptoms and criteria that a person would need to kind of meet to be diagnosed with moral injury. But it does have some key symptoms that we do recognise. So I suppose the main ones are really kind of guilt and shame. But also things like loss of trust. So it might be loss of trust in the self, or it might be loss of trust in others and kind of the world. And also sort of like an existential conflict, kind of a ruptured self-identity, or kind of beliefs about the world or others that have been kind of severely challenged. So I suppose that's kind of really the main components of moral injury. I suppose the main differences when we think about something like moral injury versus things like burnout and secondary trauma is that it's very much focused on kind of the external sort of factors that are leading to this distress. So it's very much focused on the environment that's causing an individual to act in a way that goes against their moral values, rather than it being seen as a problem because of someone's sort of ability or inability, I suppose, to cope with their workload, traumatic material, etc. And so I think that's really kind of one of the key sort of components of moral injury.
Great. So perhaps you can help me with this, because whilst you're talking, an example has come to mind, and people will laugh when I say this, but I'm not intending to be in any way flippant, really. But when I was at my junior school, when I was 10, I was very sporty. I was very good at football, cricket, running, anything really. And I was also quite good at rounders, given little badges, which they called colours, I suppose. And I remember very well my teacher, who I'd always looked up to, out these badges to people. And he didn't hand out one for me, he didn't give me one. And afterwards I went up to him, I was very small, I was about 10, and said I didn't get a badge. And he said, "You weren't considered good enough." Clearly I've been ruminating on that for a long time, so it has had some sort of effect, but it left me feeling very upset and with a kind of lack of trust. Does this kind of thing resonate with you at all?
Yeah, I mean, I think the thing with moral injury is it kind of sits, we see it as sitting on kind of like a spectrum, I suppose is the word. So, there's lots of things in the world that we might find morally frustrating, for example, things that we feel, were wrong. I suppose what moral injury is really trying to do is it's really kind of characterising the most kind of severe sort of forms of distress where a kind of a really kind of serious conflict of morals has occurred. So within Shea's definition, actually, he talks about moral injury being something where a transgression has occurred and there's been kind of what we call a high stakes element. So there's an element where there's been a potential for or actual kind of harm. So, I mean, there's lots of things and experiences that we have that we feel kind of might go against our moral values. Sometimes they might not always be kind of causes of moral injury as such. They might be more, as I said, moral frustration, or another term that we see used a lot is moral distress. I think that's one of the challenges actually in this kind of field of work is understanding the difference between these different kind of levels, I suppose, of moral responses to events.
And you're mentioning moral values quite a lot, so the construction of those for any individual is central to what you're talking about, I suppose.
Absolutely. Yeah, definitely.
So when did the concept of moral injury initially arise?
So when we think about kind of the history, I suppose, of the term, it goes back to, again, the work of Jonathan Shea. That's kind of the person that we primarily attribute this term to describe kind of the impact of war-related experiences. So that's really where it came from. So his work was very much looking at kind of impacts that war had on people returning from that kind of context. Because I suppose something that he kind of picked up on was that PTSD wasn't quite capturing what he referred to as kind of the character wound of these situations. And so he was interested in thinking about how can we kind of understand distress and the impacts that that's having on more of the kind of someone's, I suppose, sense of meaning, their belonging in kind of the world, and their integrity, which, as I said, he didn't really feel was being captured in something like PTSD. So that's kind of where it originally came from. So whereas kind of something like PTSD, we would consider it like a fear-based response, I suppose, to kind of a situation where there's perhaps a threat to life, so that sort of mortal danger element. Moral injury relates more to kind of, as I suppose as the name suggests, moral danger. So where there's kind of threats to someone's self-integrity or their kind of beliefs about the world and system. So that's really where we kind of attribute the sort of start of moral injury to. Actually, since then, and actually particularly because of the COVID pandemic, we've seen moral injury being sort of applied to understand distress in a much kind of broader range of occupational groups. So that one of those is obviously healthcare, and that's kind of my area of sort of interest and focus. But we've also seen it being looked at in child protection workers, for example, police officers, firefighters, and those kind of public sector roles, lawyers and vets as well. Some initial research around that. So yeah, came from kind of war-related, sort of a war-related background. Definitely much broader application now.
Thank you. So can you tell us a bit about the research project that you've been involved in and working on? What did you find in this project?
So I initially actually heard about moral injury through the projects that I was involved in my day job, if you like, within the CDCT. And that kind of really sparked an interest for me, which basically led me to complete a PhD programme focusing on understanding moral injury in secure mental health care. So obviously the kind of environment that I'm working in, and how we might kind of prevent and reduce that as well. So I suppose there was really kind of two parts to the research project. So the first part was around establishing kind of what are the initial sources of moral injury, and that's kind of really important because we need to know that to be able to think about some of these kind of prevention measures and strategies that we can put in place. And actually a lot of the research we had at the start of my kind of research program was looking at kind of the prevalence of moral injury symptoms. So kind of establishing, it's a thing in this group, but not so much thinking about, what are the actual experiences that are driving moral injury to kind of occur in this staff group. So in kind of consideration of that part of the PhD, I suppose the sort of overall finding was that there was a broad range of what I call them PIMEs. It stands for potentially morally injurious events. And actually a lot of the PIMEs that were coming out were quite unique to the secure mental health care setting as well. So things that perhaps aren't necessarily kind of experienced globally across healthcare, but experiences that staff working in a secure mental health care setting specifically may face as a result of that environment. So that kind of indicated actually perhaps we need to be thinking about some kind of tailored risk assessments. Organisations that are providing this kind of care need to be thinking about what are the sort of specific elements of this context that are causing more kind of moral complexities for staff that we could be sort of addressing. And actually, the other kind of really interesting finding for me was that a lot of the kind of potential sources that were coming out from that research weren't COVID-19 specific. And the reason I'm saying that is because when we look at the research that we have on moral injury in healthcare, the majority of it is very much focused on COVID-19 related experiences for staff. And that's understandable because obviously, that was a completely kind of new time for the workforce that had a lot of kind of moral complexities to it. So it makes sense that actually moral injury is something we consider for staff working in that kind of period. But actually what was coming out was that a lot of the kind of potential sources for moral injury that staff were talking about weren't kind of specific to that COVID-19 experience. So they're things that are still kind of relevant for staff as we kind of move out of that pandemic era as well. So I think that's important just to recognise that we're not kind of limiting our understanding of moral injury to just the pandemic kind of period. And then, as I said, a lot of the kind of potential sources that were coming out were actually kind of very sort of, I suppose, inherent parts of the secure mental health care system. So things that are kind of unavoidable in this sort of environment, which actually suggesting that, maybe we can't always prevent moral injury, and that there's also an element of needing to educate and prepare our staff better to work in this kind of environment as well. And so that was the first part. And then the kind of second part of the research was really focused on understanding the kind of links between exposure to a moral transgression and how that then develops into moral injury and wider effects on well-being. So things like low mood, poor sleep, problems in relationships, and those interpersonal problems, which we often see kind of coinciding with moral injury. And so I was specifically focused on thinking about kind of cognitive mechanisms that might account for that kind of translation. Because we know that actually, just as in the same way with kind of PTSD, that, exposure to a traumatic event doesn't necessarily guarantee that someone's going to develop a PTSD response. The same is true of moral injury. So just because someone's been exposed to a situation that perhaps goes against their moral values, it's not kind of guaranteed that they'll show a moral injury response to that. So I was looking at cognitive mechanisms, specifically looking at kind of early trauma. So obviously working in the trauma centre, that's kind of one of my areas of focus. And the effects of trauma on things like schemas. So schemas are kind of like mental blueprints that we use to kind of make sense of ourselves and the world as well. And those are quite strongly linked to early trauma experiences as well. So I was looking at those kind of mechanisms. So I suppose just to give you a brief overview of kind of main findings for that part of the research, I found that people who had higher levels of kind of childhood trauma and adversity and who had more kind of negative schemas, so sort of blueprints about the world, were more likely to develop moral injury once they'd been exposed to a transgression or a sense of betrayal. And the other kind of, I suppose, key finding was that actually how an individual thinks about sort of emotions like guilt and shame may also make them more vulnerable to other kind of adverse wellbeing outcomes as well. And I think that's important because when we think about kind of treatments for something like PTSD, particularly kind of the cognitive behavioural based treatments, these are primarily kind of targeting the emotions that an individual is feeling as the problem, essentially. So, for example, in PTSD, we often kind of try to minimise that fear-based response. But actually, with moral injury, we talked about guilt and shame being the primary kind of emotions for that construct. Actually, guilt and shame might be quite rational and healthy reactions to a situation where you've acted in a way that's gone against your moral values. Actually, minimising kind of feelings of guilt and shame, where perhaps to some degree they are warranted reactions, may not always be the most kind of beneficial response from a treatment perspective. So actually, how we make sense of guilt and shame might be more important. So, for example, rather than seeing guilt as an indicator that, I am bad, and those very kind of internalized meanings that we might attach to guilt, is being a bit more open and compassionate about, why you're feeling guilt and what that means about you as a person.
Thank you. That sounds like quite a comprehensive study that you've done there. Can I just take you back to the first part there? Because you obviously hinted at various sources
Yes.
For moral injury, particularly in healthcare settings, but I wasn't quite clear what you meant by those sources. Can you give some examples?
Of course I can. So with kind of sources of moral injury, I think there are a lot of nuances depending on kind of the particular sector that someone's working in. So obviously we often talk about healthcare and research, but it's a very broad sector with lots of different kind of setting types and populations that people are working with. And also, it's important to, I suppose, just keep in mind that what might be experienced as a source of moral injury for one person may not be by another. So there is a sense of kind of sort of personalisation to these as well. I suppose the core kind of theme across sources of moral injury in healthcare is that they're situations where a person has felt that they've not been able to provide the care that they should. So if we think about sort of generic ones that might be shared across healthcare, the healthcare sector, that might be things like administering inappropriate treatments. So that might be because there's a pressure to administer that treatment, or you're administering it even though perhaps you haven't got correct consent from patients, or perhaps there's an element of kind of coercion because it's not something that the patient would agree to, but it's what kind of is right for them in terms of their care. It might be that you're kind of inappropriately discharging patients, so perhaps they're being discharged prematurely, even though you know that actually they should be kind of staying because there's a pressure to free up beds. It may be that you're kind of providing care in an environment that's not suitable for that patient. So I don't know, the ward is very kind of cold and not kind of a therapeutic environment, or there's not the right facilities to allow you to have confidential discussions with patients, for example. So I think there's lots of kind of shared sources across healthcare. But my research was specifically looking at moral injury in the secure mental health care setting. So there were several kind of sort of unique parts of that environment, or experiences that were particularly kind of relevant to a secure mental health care environment that were coming up as well. So if I give you a few examples, it was things like focusing on kind of risk management to the detriment of someone's kind of healthcare needs. So obviously for staff working in a secure mental health care environment, they have a duty to kind of balance sort of risk management with the mental health and physical healthcare needs of patients as well. And often kind of the latter comes at the cost of the former. And so that was one. Things like being exposed to aggression and witnessing harm, so things like self-harm. Those are quite common experiences for staff in a secure mental health care service, and that might be a potential source of moral injury, perhaps because an individual feels like they had a duty of care to prevent an individual from causing harm to themselves and they weren't able to fulfill that duty. Or perhaps, you've been a victim of some kind of aggressive incident or assault, and you felt like the organisation or your colleagues didn't do enough to kind of protect you in that situation, for example. Another one might be something like the use of restrictive practices when other alternatives were available. So things like restraints and seclusions are practices that do occur in secure mental health care settings as well. And perhaps sometimes we don't have the resources that we feel we need to manage the situation in a different way. And so we kind of turn to things like restraints and seclusions, when actually perhaps there were other more therapeutic options that we could have taken, but perhaps didn't see that at the time.
I was thinking, Elanor, because you said that your work kind of took place against the sort of backdrop of COVID as well, and I know someone who's researching the impact on staff of being required to have the vaccine, but I guess that must have cropped up in your research in terms of informed consent and people perhaps feeling under pressure to have something that they may not have wanted to do otherwise.
Yeah, actually, that one didn't actually come up in my study, but that is a tricky one. Definitely, there's that element.
I was thinking not even just about COVID, but obviously forcible injections are part and parcel of secure practice, aren't they?
Absolutely, and so both for patients and staff, I suppose. I suppose that kind of links in with the kind of in the administration of inappropriate treatments or treatments where there's an element of coercion, perhaps.
So, just to kind of sum it up for my benefit, really, to help my understanding, when you're talking about moral injury, you're talking about something which arises through the breaching of some moral code,
yes,
or behavioural expectation, and that you would also have some kind of symptom threshold which would be crossed.
Yes, that's what's quite tricky about moral injury, actually, is that we would say there is a symptom threshold, but we don't really define it in the same way that, as I said, we do with things like PTSD, where there's very specific symptom clusters, and people would have to kind of show a particular severity in that area. So we have an idea of what it is, but it is tricky to define that specific threshold, just because we don't.
Okay, that'll be coming later. Are there some people more predisposed to experiencing moral injury than others?
Yeah, so I think in the same way that we see differences in risk for kind of other psychological outcomes, so things like PTSD, depression, anxiety, for example, we know that moral injury isn't a guaranteed response to a transgression. So two individuals who are exposed to a situation, one may develop moral injury and one may not. I think there's probably a lot of factors that determine kind of someone's response to a transgression, and I think we're only really at the beginning in terms of research in understanding kind of what those factors are and how they actually affect risk. I suppose one perhaps more obvious one would be the type of role that someone's working in. So, for example, we often see higher levels of moral injury in clinical staff than we do in non-clinical staff. And that's just perhaps due to the nature of the role that people are, occupying, and the greater risk for exposure to things like aggression, for example. And also people, as we kind of touched on earlier, people have different moral values. I think generally we do have lots of kind of shared moral values, people working in one kind of occupation. So I think across healthcare professionals, generally we probably have some quite shared moral values, but they are individual.
So what are some of the factors that protect people from moral injury?
Yeah, so we have lots of kind of wider theories that can account for sort of risk differences for other types of adversity. And I think a lot of these do apply to moral injury. So I think one of the main ones that we have really focused on is social support. Support from a social network outside of the workplace. So we have I don't want to say old theory, but a long-standing theory, I suppose, called the stress buffering hypothesis. And this is essentially the idea that the kind of presence or absence of social support shapes the way that people think about stressful events and traumatic events. So I think that's one particular area that we've looked at in moral injury quite well. So that was something that I explored in my own research. And one of the findings that I thought was really interesting actually was that people who had more negative schemas, so had more kind of maladaptive blueprints that they kind of used to make sense of the world around them, when they had so greater levels of social support, they were more likely to be at risk for moral injury, which is kind of the opposite of what we normally see in kind of research, is normally social support plays a protective factor. And it can play a protective factor, but I think how I made kind of sense of that finding was that potentially people who have more negative kind of schemas about the world perhaps have a perception that, this social support is perhaps undeserved or unwanted. And there is some initial research that actually suggests social support can have a negative effect when it's not wanted, as well as protective effects as well against traumatic stress. So I think social support is one, but actually potentially has a dual kind of role.
That's really interesting when you, like you say, it goes against what you'd intuitively think. But I wonder if the social support element might mean that something gets a bit calcified in somebody's mind. Because I was thinking about the whole notion of, say, trigger warnings. Again, intuitively, you think giving people a warning that they're about to hear potentially something difficult is helpful, but the research actually doesn't support it. It suggests people are more likely to be activated if they have the trigger warning alerting them to the content at the start. And I wonder if something similar goes on with moral injury.
So. I mean, it's not that social support doesn't have any protective effects for moral injury, because actually we have a lot of research that suggests it can be useful. But I think it might just be a little bit more nuanced than saying it's always going to be a protective factor. There may be a lot more behind how effective it is for an individual. Definitely. And I think also kind of another factor which is really important is an organisation's response to a moral transgression. So how an organisation supports an individual following a moral transgression or a betrayal. If we think about this in terms of, they say there's been an incident at work and there's kind of an investigation ongoing. You're working in an organisation that takes very much kind of a blame approach. Then that is likely to perhaps kind of reinforce someone's appraisals of themselves as being kind of guilty, and that's kind of shame response that we see to moral transgressions. Whereas if you're working in an organisation where perhaps they take a more kind of compassionate approach, they're more focused on kind of identifying lessons learned rather than assigning specific blame and responsibility for a situation, then that might also encourage a person to have a different interpretation of an event, considering kind of more the factors that led them to behave in that way, thinking about kind of their real intentions behind why they may have acted in a way, and the kind of more sort of non-malicious side of that as well. So I suppose there is the individual factors, but there's also very much the organisational part of it too that's really important.
You might not know the answer to this, Eleanor, but I suppose I'm interested in your opinion on it anyway, whether the risks of moral injury are higher for staff working in secure settings than in other healthcare
that's an interesting one. I think going by the initial data that we have, which is very limited, I suppose we could suggest that staff in this sector may be more at risk. And that may be because maybe a product of the environment. So as I said in my kind of the first part of my research, it suggested that actually there are lots of nuances in the secure mental health care environment that pose additional potential sources of moral injury. So that may be it. Or it may be to do with the kind of workforce and the type of people who decide to work in secure mental health care. And there's a really interesting theory actually called, I think it's the schema-focused model of occupational distress. I'll have to double check that, I'm pretty sure that's it. But the basic tenets of it is that people are drawn to occupations and workplace environments that mirror the environments of their early life and relationships. So if we think about that, and we think about kind of secure mental health care settings, these are environments where there's heightened levels of aggression and threat, and often quite high levels of uncertainty as well. So it may be that actually this is a staff group who have high exposure to early trauma, have high kind of levels of these maladaptive schemas, and so because of that, they're more at risk of moral injury. But those are just hypotheses. I suppose I can't give you a conclusion as to yes, they're definitely at risk. We have some data that suggests they may be, but because we're so sort of limited in terms of the data that we have for moral injury and secure mental health care staff, I don't want to put a definite answer on that.
We're having a conversation with Emily Casper very soon, who her book's called Just Following Orders, and I suppose this conversation with you is making me think about her work and actually whether there might be some roles within the NHS where people feel exonerated from moral injury because they're, the conditions in which they're having to work, they might not feel responsible for. But I do wonder whether place in the hierarchy influences someone's likelihood of becoming morally injured. Is that more likely to happen to those who are at the lower end of the hierarchy?
That's a really interesting question, actually, because we see this kind of assumption in moral injury that moral injury is a problem for kind of frontline sort of staff, for leaders to fix. So leaders are often positioned as the kind of people with the solutions, not the ones experiencing the problem. And I think that's probably likely in part influenced by if we go back to the kind of original definition of moral injury that was put forward by Jonathan Shea, who this idea of it as being a form of distress that arises when someone in an authority position does something that goes against our moral values. So very much placing that authority figure as being the kind of cause of someone's moral injury. But actually, we know that kind of people in leadership positions in healthcare, they often were frontline staff themselves at one point, and they're not built in with kind of an immunity to moral injury. And we know that actually the importance of sort of well leaders and having having healthy leadership is really important to kind of wider organisational health, but we don't really recognise that when we're thinking about moral injury, particularly in kind of research.
And hierarchy doesn't always equate to power either, does it? I was thinking, I've spoken to quite a few people who are in very senior positions who I think would probably perceive themselves as to have had a degree of moral injury because, for instance, commissioners reducing budgets or expecting a treatment to happen in an unrealistic time frame, for instance, and the person who was employed by the NHS might have been employed at quite a senior level, but actually what they were being asked to do by commissioners didn't feel
and I think
ethical.
Something that actually my colleague Deborah sometimes mentions is that actually we forget that leaders themselves have leaders and have bosses too. So actually that links in with some of the work that we've been doing within the CDCT actually, which is looking at moral injury in healthcare leaders. So, is it a thing in this group? And actually what we need both from leaders to create a morally well organisation, but also what we need to offer our leaders as well in terms of support. So I suppose to put it in one sentence, I think the context of someone's role can influence their risk, because it may be that, the types of morally injurious events will differ, but no one is immune just based purely on their role within an organisation.
Thank you. And I suppose related to that, it made me curious about the relationship between whistleblowing and moral injury, because people are often seen as whistleblowing to avoid incurring moral injury, I think. Is that your experience?
I think whistleblowing could be a response to a moral transgression. With often whistleblowing happens because someone has concerns about the morality, the safety of the situation. But I think actually the experience of whistleblowing itself and then the subsequent reactions that someone experiences to that could also be a cause of moral injury, make kind of feelings of betrayal worse. You may feel as an individual that you've perhaps betrayed your organisation or you've betrayed colleagues if you're kind of whistleblowing on kind of members of the team, for example. Or it may be that when you whistleblow, the kind of response that you receive from the organisation that you're working for, you feel is perhaps inadequate. Perhaps they fail to respond to your concerns, for example, or you might experience ostracisation and isolation from your colleagues as well. Obviously, whistleblowing does come with risks, personal costs. So yeah, I think it's a tricky one.
Thank you. And what light does your research shed on how organisations could be morally healthy?
So there was several recommendations for the kind of initial prevention of these sources of moral injury. So I think one of the main things to consider is that moral injury and kind of the source of moral injury may not always be avoidable. So I mentioned that one of the things that came out in the first part of the research was that actually a lot of inherent parts of the secure mental health care service and system may be kind of morally challenging for staff. So, they're caring for patients who have very limited access to kind of the freedoms that we kind of sort of take for granted, I suppose. They have very restricted contact with their family and friends, for example. And these are things that we can't necessarily avoid. They just are parts of that secure mental health care system. So I think educating and training staff would be really useful, giving them that language to understand that this is something that you may experience just a result of working in this kind of setting. And that may also be things like being very transparent in recruitment processes about what that secure mental health care environment might be like for them to work in. And I suppose also providing spaces and platforms for staff to support them when moral challenges do occur. So there's been a few pieces of research actually looking at the kind of usefulness of ethics consultation boards, sort of panels and spaces for staff to bring ethical dilemmas that they've experienced, and then to get kind of advice and perspectives from other people within their organisation. And the other one I'd say, which is really important, is actually supporting staff to develop social skills. So I mentioned that actually we have a lot of research looking at kind of the role of social networks, and they can be kind of protective and kind of the opposite. But actually facilitating kind of relationship building might be really important, because when we think about the healthcare workforce generally, not just secure mental health, but just kind of more broad, actually, I think it was around a fifth, the NHS statistics suggested, around a fifth of staff are actually recruited from overseas. So, are coming to the UK to work in kind of a whole new country where perhaps they don't have family and friends available to them. And many also are working unsociable hours as well, which we know is obviously going to have an impact on people's ability to kind of socialise and develop relationships. And moral injury itself can kind of exacerbate social withdrawal as well. So things like shame and guilt can make people kind of retract from relationships because they're worried about kind of people's responses to them. So I think supporting staff to develop social skills could be really important as well. I suppose I would probably signpost to a wider piece of work that we're doing within the CDCT, which is looking at how can we develop morally healthy organisations from a more kind of solution-focused perspective. So not about kind of addressing what the problems are, but how do we go about building an organisation that is going to be reducing any risks for moral injury. So that's actually just been published in the Journal of Occupational and Environmental Medicine. So that will probably give a much more comprehensive oversight to that.
I was thinking about the role of emotional literacy as well, actually, because when you think about places that are featured in the news, like the Edenville Centre for brutal staff treatment of patients, and I don't think very few people, I think, join the NHS because they want to hurt or harm others. People often join because they want to contribute something good. But I think you see in forensic, we had a conversation with Dan Lawrence, where you kind of like when you see people who are scared, they don't have a way of managing their emotions at work, then people often respond with aggression, don't they, rather than finding a more emotionally literate way to manage the situation.
And I think also that links in nicely with this idea of emotional labour, which is essentially the kind of requirement for an individual to withhold their or suppress their true emotional response in a situation. For example, I suppose linking it to the secure mental health care setting, if you're a staff member and you found yourself in a situation where you're needing to restrain patients, that can be very distressing for both the patient and the staff member. But for the staff member, there's an expectation that you need to suppress that response because it's the professional thing to do. And so, if you don't have any outlet to kind of discuss those emotions and those kind of reactions that you've had to that situation, then it's about how can you healthily kind of sort of regulate that emotional response.
Thank you, Elanor. While I'm thinking of it, if you can send us any links to any of the published work that you've either done or referred to, we can put them in the show notes. So thinking about you, you work in a secure hospital. You must be hypersensitive to the possibility of moral injury. How do you protect yourself?
Yeah, so I think ultimately the key driver for moral injury and the risk of moral injury is within the organisation and system. That's not to say there aren't kind of more individual level steps that we could take to kind of reduce the impact of these sources of moral injury. So I suppose just kind of linking in with what we were just talking about, I think having literacy in this area, understanding what moral injury is and what does it look like and why might it develop and how is really important. And something that kind of came up and it did actually surprise me when I was doing my PhD research was the amount of people that said to me, "Oh, I don't know what moral injury is. What is moral injury?" And so actually it is a new term to many people, despite its kind of relevance to explaining people's distress. A lot of people don't have that language to make sense of it. So I think just being aware of moral injury, it sounds simple, but being aware of moral injury can be useful in allowing people to recognise perhaps that that's what they're experiencing when it's occurred, and then allowing them to then think about appropriate support that they're going to need for that. And I think another key one is making use of protected supervision spaces and feedback forums. I'm fortunate enough that I work in a great team. Obviously, the reality is that might not always be something that an individual has access to. But I think having that supervision space is really key as well. So I suppose those are kind of two main ones. I think it is important to recognise that actually protection from moral injury isn't always completely possible. And I suppose something also which someone said to me once was, isn't the cure for moral injury just not having a moral compass? Well, actually, I think that's probably more harmful is having a workforce without a moral compass than having a workforce that, has the potential to experience things like moral injury as well. So,
Great.
Thank you.
Thank you.
Thanks very much indeed.
Thank you, Elanor.